Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
Hi, listeners. Today we're reviewing recurrent platinum-resistant epithelial ovarian cancer. Since we originally aired this episode, there have been a lot of changes in this space, so we've re-recorded this full episode. We hope you find this episode helpful to synthesize the new updates. Sydney, what are our learning objectives?
Our objectives are to define platinum-resistant ovarian cancer and explore its prognosis, to describe an approach to treating patients with platinum-resistant ovarian cancer, to discuss targeted therapies and its management, and to review systemic chemotherapies in the management of this disease.
Let's get started. As a reminder from our last episode, platinum-resistant disease is defined as recurrence of disease within 6 months of finishing your original or most recent platinum therapy, and platinum refractory indicates progression of disease while on initial or first-line treatment of platinum. In general, because of these poor responses, retreatment with a platinum compound is not recommended. Median progression-free survival is unfortunately low with retreatment of platinum-resistant tumors. It's quoted at typically 5 to 6 months, with response rates that are usually either partial response or clinically stable disease between 10 to 30%. Historically, life expectancy for these patients was about a year, but we have promising results with newer therapies, resulting in patients living longer.
For platinum-resistant disease, options include systemic therapy or best supportive care. Systemic therapy can include therapy on clinical trial, cytotoxic chemotherapy, or targeted therapies. Most of the trials for recurrent therapies are randomized phase 2 trials. Thus, the majority of the recommendations in NCCN are category 2A or 2B. Regardless of the choice for retreatment therapy, reevaluation should occur after 2 to 4 cycles to determine if patients are deriving a benefit. For patients who progress on 2 consecutive chemotherapy regimens without clinical benefit, the NCCN states that these patients may not benefit from additional therapy.
Choosing a treatment pathway for platinum-resistant epithelial ovarian cancer can be very challenging, as there isn't always a clear right answer. We're going to review a general approach to treating these patients, which is a system that I've learned from Dr. Heidi Gray, my attending at the University of Washington. First, it's important to understand the patient's goals of care, their performance status, and their ability to tolerate chemotherapy, understanding that in some cases, best supportive care will be the best option. This is the right time to do advanced care planning and incorporate palliative care if you haven't already. Then, screen your patient for clinical trials. Most clinical trials for platinum-resistant ovarian cancer include a control arm with a standard of care chemotherapy, so patients on trial will be receiving an active agent. For earlier phase trials, there are limited spots, so it's helpful to get your patients screened early. After screening for clinical trials, review your patient's somatic and germline data to assess for targeted therapies which might be applicable. In the current era, these often might be the next best step in a platinum-resistant patient, given low response rates to standard single-agent chemotherapy. Finally, if the above options aren't a good fit, consider your chemotherapy choices. This will typically be a single-agent cytotoxic treatment, plus or minus a targeted therapy. When choosing your therapy, consider previous responses to chemotherapy, as well as toxicities on prior therapies, which might impact your patient's quality of life with new treatments. Let's discuss current targeted therapy options for platinum-resistant ovarian cancer, which have really expanded in recent years.
As in other disease sites, antibody-drug conjugates are emerging as really good options in platinum-resistant ovarian cancer. We'll start by discussing mirvetuximab soravtansine. This agent is a folate receptor alpha antibody conjugated with a microtubule inhibitor. In 2018, the Phase 3 Forward 1 trial was published comparing mirvetuximab versus investigator's choice chemotherapy in platinum-resistant epithelial ovarian cancer. This study did not meet its primary endpoint of progression-free survival in the intention to treat population or the folate receptor high population, meaning greater than 75% of cells with greater than or equal to 2 plus IHC staining. However, the overall response rate was higher in the FR alpha population, with a 24% versus 10% response rate in the MIRV versus chemo groups. There were fewer treatment-related events leading to dose reduction or discontinuation in the MIRV group compared to standard chemotherapy. MIRV does have some unique toxicities, particularly in the eye, which we will further explore in our biologics episode. With the results of Forward 1 in mind, the Phase 3 Mirasol trial was designed to evaluate the activity of mirvetuximab in patients with high FR alpha expression. This was published in the New England Journal of Medicine in 2023 with final overall survival results published in 2025. Patients were randomized to MIRV versus chemotherapy, being paclitaxel, liposomal doxorubicin, or topotecan. Of the 453 patients enrolled, 62% had received prior BEV therapy and 55% had received a prior PARP inhibitor. Progression-free survival improved from 4 months in the chemo group to 5.6 months in the MIRV group. Overall response rate improved from 16% to 42% in the mirvetuximab arm. 5.3% of patients in the MIRV group had complete responses versus no patients in the chemo group. Most importantly, though, overall survival improved from 13 months to 17 months in the mirvetuximab group. This study led to full FDA approval of MIRV for folate receptor positive, platinum-resistant ovarian cancer for patients treated with up to 3 prior therapies. In 2023, Gilbert et al. Published a Phase 2 trial evaluating the combination of mirvetuximab with bevacizumab in patients with platinum-resistant epithelial ovarian cancer. All of the included patients had a folate receptor alpha saturation of greater than or equal to 25%. 52% of the included patients were heavily pretreated with greater than or equal to 3 prior lines of therapy, and 59% had received prior bevacizumab. The overall response rate was 44%, and 5 of the 94 included patients had a complete response. Duration of response was 9.7 months, with a progression-free survival of 8.2 months.
Other antibody drug conjugates which can be employed currently for platinum-resistant ovarian cancer include trastuzumab deruxtecan, which can be given for HER2, 2 plus or 3 plus tumors based on the results of the Destiny Pan-Tumor 2 trial, and the tumor-agnostic FDA approval, which we have previously reviewed in our advanced uterine cancer episode. Additional ADCs are under investigation in this disease site.
Bevacizumab is another option for targeted therapy in platinum-resistant ovarian cancer and can be used as a single agent or in combination with other agents. In fact, it carries a 2A recommendation from NCCN for single-agent therapy and in combination with other chemotherapies for both recurrent platinum-sensitive and platinum-resistant disease. The overall response rate is about 20%. It is contraindicated if the patient has a risk of GI perforation, as this can be a fatal side effect. This has been studied in several trials. The first to discuss is GOG 170D, discussed in our last episode, which evaluated single-agent bevacizumab until disease progression or unacceptable toxicity for persistent or recurrent platinum-sensitive and platinum-resistant ovarian cancer. The overall response rate was 21%, and the progression-free survival at 6 months was 39%. 10% of patients experienced hypertension, but there were no GI perforations or fistula formation seen in the trial. Platinum sensitivity, age, and number of prior lines of therapy were not associated with response. The Canistra trial, published in 2007, was a Phase 2 study evaluating single-agent bevacizumab exclusively in platinum-resistant ovarian cancer. The trial included 44 patients who had progressed within 3 months of discontinuing their prior therapy and had been treated with a maximum of 3 prior lines of therapy. The median progression-free survival was 4 months and median overall survival was 11 months. Notably, 11.4% of the overall enrolled patients had a GI perforation. And in the patients with 3 prior lines of chemotherapy, the GI perforation rate was 24%. This was compared to 0% in the 2 prior lines group. So, taking into account GOG 170D, whose inclusion criteria had a maximum of 2 lines of prior therapy, used the same dosing schedule, and had 0% risk of perforation, these 2 studies suggest that the risk of GI perforation may be higher in patients who are heavily pretreated.
The Aurelia trial was a phase 3 trial published in 2015, which evaluated the use of bevacizumab in combination with chemotherapy in recurrent platinum-resistant ovarian cancer. Patients with more than 2 prior lines of therapy, those with platinum-refractory disease, or history of bowel obstruction were excluded. Investigator choice chemo included paclitaxel, liposomal doxorubicin, or topotecan. Crossover to bevacizumab was allowed. The addition of bevacizumab improved progression-free survival from 3.4 to 6.7 months, and the response rate from 12 to 27%. In the intention to treat population, the overall survival difference was not statistically significant, but differed by a 3-month trend. The majority of patients on the study had not been treated with bevacizumab before, so it's hard to know how to extrapolate this to patients who previously have received Bev. In sub-analyses, the study noted that the Taxol and Bev group derived the most benefit from Bev and had the highest response rate, with 53% versus 30% in the Taxol alone group. As a result of this, many providers feel that Taxol and Bev is the most active regimen in platinum-resistant ovarian cancer. From the Aurelia trial, weekly Taxol, liposomal doxorubicin, and topotecan in combination with Bev are recommended by the NCCN for recurrent platinum-resistant ovarian cancer. 2 years later, an exploratory analysis of the Aurelia trial was published to evaluate the effect of the high crossover rate to bevacizumab from single-agent chemotherapy that was seen in this study. Of the 182 patients randomized to the chemotherapy alone group, 78 were ultimately given bevacizumab after progression on single-agent chemo. Compared with the patients who never received bevacizumab, patients with upfront chemo plus Bev or those who received Bev after progression had a reduced risk of death with a hazard ratio of 0.68 and 0.6 respectively. There was equivalent tolerance between those receiving bevacizumab upfront or after progression. This exploratory analysis called into question whether the high crossover rate to bevacizumab in the Aurelia study confounded results in the intention to treat population, because when the group who ever received bevacizumab during the study was analyzed, the overall survival benefit was statistically significant.
The use of immunotherapy in ovarian cancer is evolving and is dependent on histology, molecular markers, and combination with other agents. Recall our discussion of immunotherapy utility in clear cell ovarian cancer from our less common ovarian cancers episode. In platinum-resistant ovarian cancer, immunochemotherapy regimens seem to have the most promise as opposed to immunotherapy alone. Let's talk about some trials which inform this conclusion. The Keynote B96 trial was published in 2026 in The Lancet. This was a phase 3 double-blinded randomized control trial evaluating weekly paclitaxel plus pembrolizumab versus placebo every 6 weeks for platinum-resistant ovarian cancer. Bevacizumab was allowed at clinician discretion. In this study of 643 patients, there was an overall survival benefit in the intention to treat population with the addition of pembrolizumab to Taxol. Bevacizumab had previously been used in 46% of patients and was used in 73% of patients during the trial. The overall survival in the pembro-Taxol group was 17.7 months versus 14 months in the Taxol alone group, with a hazard ratio of 0.82. The benefit was slightly increased in those with a CPS score of 1 or greater, with a hazard ratio of 0.76, but benefit was observed in both groups. Additionally, the use of bevacizumab did not seem to modify the effect of pembrolizumab when added to paclitaxel. The current NCCN recommendation for this combination is in PD-L1 positive tumors. However, these are based on second interim results, which exclusively showed an overall survival benefit in PD-L1 positive tumors, not the final overall survival reports, which had an overall survival benefit in all comers. We anticipate this NCCN recommendation may change. Oral cyclophosphamide with pembrolizumab and bevacizumab is another immunochemotherapy combination evaluated by Sierras et al. In a phase 2 trial published in JAMA Oncology in 2020. 75% of patients included had platinum-resistant ovarian cancer. The overall response rate was 47% overall, with 35% in PD-L1 negative disease and 53% in PD-L1 positive disease. The median progression-free survival was 10 months and did not differ based on PD-L1 status. This regimen is listed in the NCCN guidelines under other recommended therapies.
That's really interesting. So overall, the use of immunochemotherapy is an exciting option in platinum-resistant ovarian cancer. Let's briefly review some of the other studies which have investigated immunotherapy in this space. The NINJA trial was a phase 3 RCT in patients with platinum-resistant epithelial ovarian cancer published by Hamanashi et al. In 2021. Patients were randomized to nivolumab or standard of care chemotherapy with either gemcitabine or liposomal doxorubicin. Overall survival did not differ between the groups, and the PFS was actually worse with nivolumab at 2.0 months versus 3.8 months. Keynote 100 was a phase 2 study published in 2020 in JCO. It evaluated the utility of pembrolizumab monotherapy in platinum-resistant ovarian cancer in 2 cohorts stratified by the number of previous treatment lines. In both groups, the overall response rate was less than 10%. In exploratory analysis of patients with a CPS greater than or equal to 10, the overall response rate was higher. In the heavily pretreated group, the overall response rate improved to 18%. In those with a combined positive score greater than or equal to 10, the overall survival was 22 months and 24 months in the 2 cohorts. 75% of patients on trial had treatment-related adverse events, 20% of which were grade 3 to 4. There were 2 treatment-related deaths due to Stevens-Johnson syndrome and hypoaldosteronism. Another trial, Topazio/Keynote 162, published in 2019, was a phase 2 trial which evaluated the combination of pembrolizumab and niraparib in 62 patients with recurrent platinum-resistant epithelial ovarian cancer. The overall response rate was 18%, and 5% of patients had a complete response. HRD status and BRCA mutation were not associated with response. As with other uses for PARP inhibitor in platinum-resistant ovarian cancer, this combination is not listed or recommended by the NCCN.
In 2020, NRG GY003 was published evaluating the combination of nivolumab and ipilimumab versus nivolumab alone. To refresh your memory, ipilimumab targets CTLA-4, a checkpoint antigen on T cells that suppresses the, quote, priming phase of the immune response. In this phase 2 trial, the 100 enrolled patients had persistent or recurrent epithelial cancer, most with high-grade serous histology. 63% of these patients had platinum-resistant disease. The addition of ipilimumab statistically significantly improved progression-free survival from 2 to 3.9 months, only a 1.9-month difference. Overall survival was not different. The combination regimen was more toxic and had higher rates of discontinuation. In exploratory analysis, patients with poor prognostic markers, meaning low performance status, platinum resistance disease, older age, or more prior regimens, seem to derive relatively more benefit with the combination regimen compared to single agent therapy. Patients with clear cell histology also responded more robustly. This combination was investigated specifically in clear cell gyn cancers in the MOST circuit trial, where it had a 53% response rate. We discussed this in more detail in our updated episode about less common epithelial ovarian cancers. This regimen is currently listed specifically for clear cell cancer.
There's one more targeted therapy that we wanted to review. Pazopanib is a multi-targeted tyrosine kinase inhibitor, which inhibits VEGF, which is an option in the NCCN guidelines, best for patients that have low volume recurrent ovarian cancer. This Category 2B recommendation in platinum-resistant ovarian cancer is based on the results of a small phase 2 study investigating single-agent pazopanib, published by Friedlander et al. In Gynonc in 2010. This study found an 18% response rate in patients with measurable disease, and it was relatively well tolerated. Let's discuss cytotoxic chemotherapy in platinum-resistant ovarian cancer and some exciting new updates.
In general, expert consensus opinion is that combination therapy does not typically give additional benefit over single agent treatment in the platinum-resistant recurrent setting. Toxicities tend to increase substantially with combination treatment, which are difficult to justify with a lack of clinical benefit. There isn't one ideal single agent treatment, given that response rates to most agents monotherapy are about 10 to 20%. Potential other single agent cytotoxics include docetaxel, cyclophosphamide, oral etoposide, liposomal doxorubicin, and topotecan. Some of these agents can be given in combination with other targeted agents, as we've previously discussed. In our last episode, we reviewed the Gordon trial, which investigated Doxil versus topotecan in recurrent ovarian cancer. This included patients with both platinum-sensitive and platinum-resistant disease and stratified them by platinum response and bulky disease. In the platinum-resistant group, there was no difference in progression-free survival or overall survival between the two agents, including in patients with bulky disease. Stratified by bulky disease, there were also no differences. As we discuss in the Aurelia trial, weekly Taxol is usually the most active single-agent chemotherapy in platinum-resistant ovarian cancer, with response rates about 30% depending on the trial. There are also many other agents listed as single-agent options in the NCCN guidelines, and again, considering toxicities and previous responses can help guide choices.
Cytotoxic chemotherapy got a welcome boost with the publication of the Rosella trial in 2025. Rosella is a phase 3 RCT which built on this understanding of paclitaxel as a preferred agent in platinum-resistant ovarian cancer and combined albumin-bound paclitaxel with a novel agent, relacorilant. Albumin-bound paclitaxel was chosen as opposed to paclitaxel as it does not require pretreatment with steroids. Relacorilant is a glucocorticoid receptor antagonist, found to be synergistic with paclitaxel in preclinical and earlier phase clinical trials. This trial enrolled patients with platinum-resistant ovarian cancer who had all received prior BEV and excluded platinum refractory patients and those who had a requirement for high-dose steroids. Patients were randomized to weekly nab-paclitaxel with or without relacorilant. Note that the dose of paclitaxel is reduced when combined with relacorilant due to inhibition of CYP3A4. The primary endpoints were PFS and OS. Of 381 randomized patients who had been heavily pretreated, both PFS and OS were improved with the addition of relacorilant. Median overall survival was 16 months versus 11.5 months with a hazard ratio of 0.69. Adverse events were similar between the two groups. The study is exciting as it provides a new option with an overall survival benefit in an unselected population that doesn't require a specific biomarker. An ongoing study is investigating this regimen in addition to bevacizumab, and we eagerly await these results.
Thanks, Maya. That's really great to hear. Earlier, we discussed choosing regimens based on prior toxicity. Let's say I have a patient who has undergone prior combination platinum therapy and now has significant peripheral neuropathy. Are there any agents that are, quote, gentler in this case?
Yeah, in this case, topotecan or gemcitabine may be a good option since they have better neuropathy profile. Typical side effects include alopecia, nausea and vomiting, and myelosuppression. Another lifestyle-conscious treatment is etoposide. Because it has an oral option, it can be a good thing for patients who need breaks from infusions, who have to travel far for treatment, who aren't very symptomatic or who have low-level disease. Sydney, what about PARP inhibitor? We mentioned earlier that we don't use these agents in platinum-resistant ovarian cancer.
Yeah, you're right. Similarly to our last episode on platinum sensitive disease, the FDA indications, or lack thereof, for PARP inhibitors have changed in recent years. At this time, PARP inhibitors are neither approved for use nor shown to be effective with platinum resistant ovarian cancer. There have been several phase 2 studies evaluating the response in platinum resistant disease, informing this statement. In 2015, Kaufman et al. Evaluated olaparib monotherapy in patients with platinum-resistant disease with a germline BRCA1 or 2 mutation. Overall response rate was 31%. In 2016, Domchek et al. Performed a similar study with olaparib monotherapy in heavily pretreated germline BRCA1 or 2 patients with a 30% response rate and an 8-month progression-free survival. The bottom line from these two studies is that response to PARP inhibitors in platinum-resistant disease, regardless of BRCA status, is very low. In 2022, the Ariel 4 survival data was presented at ESMO Congress investigating rucaparib monotherapy versus standard of care chemotherapy in recurrent BRCA-mutated epithelial ovarian cancer. This trial included patients with both platinum-resistant and platinum-sensitive disease. When further stratified into the platinum-resistant group, a survival detriment was seen with overall survival of 14.2 months versus 22.2 months in the rucaparib monotherapy versus standard of care chemotherapy group.
Our discussion wouldn't be complete without mentioning the patients who can no longer tolerate cytotoxic, immunologic, or biologic therapy. Endocrine therapy can be considered in patients who have limited or no symptoms with evidence of progression. In a Cochrane review, tamoxifen has been found to have a 10% overall response rate, and letrozole also has about a 10% response rate in recurrent ER-positive ovarian cancer.
You probably gleaned from today's episode that even though we continue to have increased therapy options available, heavily pretreated disease is still a challenge. Involvement of palliative care can be beneficial both for alleviating cancer-related symptoms and for assistance in management of end-of-life care. The majority of patients who develop a malignant bowel obstruction will have a life expectancy of less than 6 months. Palliative chemotherapy, G-tube placement, or even TPN can be topics of conversation, but this needs to be individualized to the patient. Lastly, hospice care with the goal of patient-centered end-of-life care should not be underemphasized. In future episodes, we'll discuss principles of palliative care and end-of-life management.
That's all we've got for you today for this 4th episode in ovarian cancer. Still to come are rare types of epithelial ovarian cancer, germ cell tumors and sex cord stromal tumors, and surgical considerations for ovarian cancer. Here are our takeaways for today's episode. Platinum-resistant ovarian cancer describes progression within 6 months of finishing either original or most recent platinum-based therapy, and platinum-refractory disease describes those who progress while on their initial platinum-based therapy. Patients with platinum-resistant or refractory disease generally have a poor prognosis, with historic response rates to chemotherapy between 10 to 30%. Options for treatment include clinical trials, targeted therapy, cytotoxic therapy, or a discussion of best supportive or palliative care. The incorporation of palliative care is recommended for patients with platinum-resistant ovarian cancer.
Targeted therapies have advanced significantly for platinum-resistant ovarian cancer in recent years. Mirvetuximab is an antibody-drug conjugate targeting folate receptor alpha and is FDA approved for patients with FR alpha positive, meaning 75% or greater, platinum-resistant ovarian cancer based on the Marisol trial. It can also be combined with bevacizumab in patients with lower folate receptor expression. Trastuzumab deruxtecan is an ADC option for those with HER2 positivity.
The GOG 170D trial, Canistra trial, and Aurelia all evaluated the use of bevacizumab in platinum-resistant ovarian cancer. In all trials, Bev improved PFS. The Aurelia trial demonstrated an additional benefit from adding Bev to chemotherapy. Based on these trials, bevacizumab as single agent or in combination with chemotherapy is an option for patients who are not at elevated risk of GI perforation.
Immune therapy and checkpoint inhibition have had mixed results in platinum-resistant ovarian cancer, but immunochemotherapy combinations have been promising. Keynote B96 demonstrated an overall survival benefit for platinum-resistant ovarian cancer with the addition of pembrolizumab to weekly Taxol compared to weekly Taxol alone. Bevacizumab was allowed in this trial and did not modify the benefit seen with immunotherapy. Oral cyclophosphamide with pembrolizumab and bevacizumab is another combination with activity in platinum-resistant ovarian cancer.
Single-agent cytotoxic chemotherapy is recommended in platinum-resistant ovarian cancer due to minimal benefit with the addition of multiple agents. The phase 3 Rosella trial demonstrated a 4-month overall survival benefit when adding relacorilant, a glucocorticoid receptor antagonist, to weekly albumin-bound paclitaxel in platinum-resistant ovarian cancer. This regimen is now FDA approved and recommended by the NCCN.
PARP inhibitors are not approved or recommended for use in platinum-resistant ovarian cancer, based on updated survival analyses from Ariel 4 showing a survival detriment for PARP inhibitors in the platinum-resistant setting.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at Ready, Set, GYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson. We'd like to thank Dr. Ryan Spencer, faculty at the University of Wisconsin, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.